Hello, everybody. I'm a radiation oncologist, and radiotherapy is frequently the forgotten specialty. It's really a forgotten specialty. It happens behind the closed doors, frequently along locked corridors. The people go there and they come out with certain side effects, and this is everything that the rest of the doctors pretty much see. The radiotherapy has always been one of the main modality, and what I'm planning to talk about today is the radiotherapy as a radical treatment for cancer of the cervix. Of course, radiotherapy does have much wider role in the management of cervical cancer. It is a very good palliative treatment. You can use it for stereotactic radiosurgery these days is particularly efficient in eliminating single metastases from here and there, but I'll concentrate my talk on the radical settings, the radiotherapy in radical settings. There are a couple of sad realities that every one of us faces when we start dealing with cervical cancer. And these sad realities are related to the cancer itself. I mean, this is the second most common cancer in women in Bulgaria. Believe it or not, it is actually very common. There is nothing rare in cervical cancer these days. And every year between 12 and 1,300 patients are diagnosed in this country, and around 350 women actually die of it. So pretty much it's a woman a day that dies of cervical cancer. A large proportion of these cases are related to only two HPV strains, and this is number 16 and number 18. And you probably, all of us have seen these magnetic resonance images of a cancer of the cervix, and if you look carefully, I don't know whether the mouse works here, but you may be able to see tiny lymph node. No, it doesn't work. A lymph node. Here, this is a patient that is from Monday, actually. No, it's okay. It's okay. Let's just leave it. Right. The sad reality has different aspects as well, and this is the medical aspects of the sad reality, and this is even sadder than the first set of sad reality facts. And this is that Bulgaria, at least for now, doesn't have a robust national screening program. It used to have one. It died. It became an occasional opportunistic screening, which is certainly not the way of doing screening. The vaccination program, which started actually quite well, was literally assassinated by anti-vaxxer groups, and from around 20 to 30% of vaccinated children, now we are down to 2 to 3%, which is a real disaster. On top of that, there is little to no collaboration between the different medical specialties, and only now we're trying to create some network and a certain agreed pathway along which these patients could be treated. Fee-for-service system, as Bulgaria has, of reimbursement, does not foster the collaboration in general. Every single specialty is trying to provide maximal treatment upfront and be reimbursed for that. So certainly the reimbursement system is not conducive to very good staging. A lot of the people that do the primary treatment actually are not funded to do the staging of the patient. And international guidelines, although well known, well published, frequently ignored, and the local expert opinion becomes a dominant way of approaching these patients. Am I right? Certainly it is true for Bulgaria. Here I've put the staging of the cancer of the cervix, not to insult the background of the people here, but to make an important point. Stage 1, the cancers that are confined to the cervix. Cancers, well, soon they go outside of the cervix, become stage 2. In stage 3, they reach the pelvic side wall or lower third of the vagina, as well as hydronephrosis puts the patients automatically in stage 3. And infiltration of other organs or metastasis places the patient in stage 4. One thing I've learned very early in my professional life, it came from one of my professors who used to say, never stay on the way of a surgeon with a sharp scalpel in hand. However, the role of the surgeon really is somewhere here, in this, here. Up to 4 centimeters in size. As soon as the tumor is larger than 4 centimeters in size, this is not territory for surgery anymore. Wertheim hysterectomy remains the main treatment modality, and although it's been modified, and certainly the fertility preservation is something very important these days, it pretty much remains the main surgical approach. It actually has been developed in 1898 in Vienna. It was an interesting time in Vienna. This was the time when Sigmund Freud was treating his first patients. It was the time when Gustav Klimt have done the drawing of the kiss and put the beginning of session as an art movement. It does include removal of the uterus and adnexy, resection of parametrial tissues, and pelvic node dissection. Even after radical surgery, radiotherapy is often needed. And the usual indications are the involvement of the pelvic lymph nodes. Even one pelvic lymph node gives you an indication for postoperative radiotherapy. If there is a lymphovascular invasion, it's actually enough to find some tumor in the lymphovascular spaces. You don't even need involved lymph node in order to earn your postoperative radiotherapy. If there is a deep infiltration of the underlying tissues, and frequently 5 millimeters is used for cutoff, and if the tumor is larger than 4 centimeters, and frequently we actually have a combination of any of these factors. One thing I've learned very early, together with the story with the surgeon with the scalpel, and this is that using 2 radical treatment modalities in treating one cancer does not cure more patients. It just provides them with double set of side effects. So we should really try to avoid using surgery and post-op radiotherapy. If the patient needs post-op radiotherapy, they shouldn't go for surgery on the first place. Yes, and there is a big stamp that we should really avoid this sort of approach. Radiotherapy has changed quite significantly throughout the years. These days is mostly based on so-called intensity modulated radiotherapy, which is a different way of delivering the radiation, which allows to avoid the normal tissues and deliver the radiotherapy where we think the cancer may be or where we actually see the cancer. It is highly sophisticated, computer-generated map of radiotherapy. Of course, the X-ray beams go in a straight direction. They cannot go in any other way. But by modulating the intensity in different parts of the beam, it allows us to deliver the dose not in a straight line, but in a sort of curved shape. Most of these cancers, large proportion of them, are squamous cell carcinomas. They're very sensitive to radiotherapy, especially the ones that are driven by HPV, which is pretty much 85 to 95% of the cases. Usually we combine it with cisplatinum. There have been a couple of prospective randomized studies looking at the role of concurrent chemotherapy, and it's clearly proven that it improves both disease-free and the overall survival. The tumor is surrounded, however, by sensitive tissues, and we do have some restrictions on what we can deliver, even with the most modern ways of delivering percutaneous or external beam radiotherapy. Certainly, IMRT made a revolution. So this is a small example. This small example of the modern radiotherapy plan, where you can see that the areas that we would like to irradiate receive certain dose. In the same time, the small bowel, which is in front, is relatively spared, the same way that the rectum behind is spared. The other thing that I would like to sort of point out, and we'll see it a little bit better on the next slide, is that the involved pelvic lymph nodes actually receive higher dose, while everything else receives a relatively low dose. So IMRT allows one thing called dose painting, different parts of the irradiated volume to receive different doses of radiation. And this is just an illustration how the pelvic lymph nodes actually receive significantly higher dose. This is actually important because while for the primary tumor we have something else up our sleeve, percutaneous or external beam radiotherapy is the only treatment modality that we have for the pelvic nodes if you're not going to do a pelvic dissection. The main problem in the management of cervical cancer in Bulgaria is that, it's a general problem. External beam radiotherapy cannot deliver the dose that could reliably control the primary cancer in the standard way, just because we are limited by the dose that we can give to the bladder and to the rectum. Therefore, these people were frequently operated after percutaneous radiotherapy with massive rate of complications. Surgery after external beam radiotherapy is not a mean feat, it is quite a serious undertaking. And probably that's why this has never been a part of the routine approach to this disease. Normally the patient will be treated either with surgery or with radiotherapy, and in my mind, every time when you need to irradiate after the operation, it means that we've missed something. We've missed something in the assessment, or we've missed something in the assessment of the tumor usually. So what is my approach and what is the current approach of my hospital? We haven't discovered anything. It is just implementation of something that has been in the international guidelines for many years. First, to start the patient with external beam radiotherapy. Normally takes 5 weeks. The beauty of it, that it addresses the issue of the potentially involved pelvic nodes. They may be seen, in which case they will be receiving much higher doses of radiotherapy, or they may need to be irradiated prophylactically, in which case they will receive a relatively low dose of radiotherapy, but they will be irradiated. And the other thing that the radiotherapy, external beam radiotherapy does is to significantly reduce the tumor size. Again, these are highly sensitive to radiation tumors. Not as sensitive as small cells, but they are sensitive tumors. And in the end of the 5-week course, the tumor is usually half of its original size, at least, and frequently significantly smaller. External beam radiotherapy will be followed up by brachytherapy, which delivers additional dose of radiation that is already given by the external beam radiotherapy. It actually consists of placing special applicators in the uterus and in the vaginal walls. I'll show you some pictures in a second. And is usually done under short general anesthetic. Each application lasts for around 10 minutes. And we normally do 3 to 4 brachytherapy procedures in the end of the radiotherapy. Pretty much all the cases with tumors that are beyond 1B1 or 4 centimeters in size. I mean, if you remember, 4 centimeters is pretty much everything for the younger colleagues that you need. These are the people that are indicated for radiotherapy. They will be treated with radiotherapy combined with chemotherapy. They will receive 45 gray in 25 fractions. This is a dose that with IMRT is pretty much without side effects, besides some irritation of the bladder and the rectum. All the patients will have their disease stage with PET scan or at least with contrast-enhanced CT. Unfortunately, the Bulgarian system is not particularly well directed towards staging patients, generally. If they involve node, they'll receive an additional dose of radiotherapy, and while the rest of the pelvis receives 45 gray, the involved nodes will receive 55 in the very same 25 fractions. This is called simultaneous integrated boost. Surgery would not be part of the radical treatment. I think it's very important. And no adjuvant chemotherapy will be given after the completion of treatment. There were enough studies to show that chemotherapy after combined chemoradiotherapy does not produce anything else but toxicity. If they involve para-aortic lymph nodes, very important to look at the para-aortic area actually. They will receive the same dose and in the same dose schedule as the pelvis. They will be treated together with the pelvis. However, we do not do prophylactic nodal irradiation, so just high risk is not an indication for radiotherapy. And we have a way of following up these patients and addressing that issue on the later stage if needed. Special attention is normally paid to the lower extension of the tumor. Gynecologists always examine their patients. Radiation oncologists sometimes examine their patients. Medical oncologists never do. But low extension of the tumor is one of the things that it's very easy to miss in the radiotherapy fields. Post-radiotherapy surgery is actually not something that's completely out of question, but at the moment we reserve it only for the patients that have fistulas, because we cannot really hope that the radiotherapy on its own will resolve that issue, and therefore these people will receive much lower dose of radiation. If they're going to go for surgery, then we give them 36 gray. It is significantly less to the pelvis, and pretty much that's it. If they involved pelvic nodes, they will receive simultaneous boost, but the primary tumor would not receive higher dose. We'll rely on the surgeons to take care of this. Follow-up is very important with this type of approach. We do have relatively easy access to PET scan, and we do PET scan 3 months after the completion of the treatment, really to ensure a response. This is everything that we want to see. We want to see metabolically inactive cervix and metabolically inactive lymph nodes. Pretty much this is what we can expect 3 months after the treatment. 6 months later, after the first PET scan, we do a second one, or 9 months after the completion of treatment, and this scan is really directed towards para-aortic lymph nodes, especially if they haven't been irradiated. Frequently it takes 6 to 9 months for them to declare themselves. In the most recent AJCC version 8, para-aortic lymph nodes are not metastatic disease anymore, they are N3. And rightly so, because this is a situation where you can still hope for cure. So involvement of para-aortic lymph nodes is not a death sentence, it's not an indication for systemic palliative treatment, it's an indication for further radiotherapy. And then we do once a year for the next 3 to 5 years PET scans, and I'll mention it, the same issue, I'll mention it a little bit further down the line. So this is if you haven't seen these things, just to show how the brachytherapy machine looks like. It has a tiny, it's really tiny, around 5 millimeter long, very active radioactive source, which stays on a very long wire, and this wire is curled in the head of that machine. That little radioactive source will go out along these tubes and get into the applicators that are in the patient. This is how the applicators look like. This contraption consists of so-called tandem. This is something that goes in the uterine cavity. It gets sounded before the procedure, and it's not always very easy because this is not a normal cervix that we're talking about. It's highly deformed, frequently stenotic cervix. We normally manage to get into it. By the way, this is a procedure that in my hospital is done by radiation oncologists. It's just simpler than trying to involve the gynecologists as well. And it has 2 ovoids that stay on the side. This is how the whole applicator looks like. And this is how it looks like in the patient. So you have the tandem and the 2 ovoids. And this is where this is project well. This is where the uterus stay, and these are the ovoids in the vagina. Again, this is highly deformed vagina. Normally after radiotherapy, if you have had cancer there, it is you don't have the phonesis anymore. You frequently have a very sort of like a Gothic cathedral arc, basically a cone of a vagina which ends up with a tiny hole. It is quite different from the normal anatomy. And this is how the dose distribution looks like from that contraption that we've put in the cervix. You can probably orient yourself. These are 2 ovoids somewhere here that are in that are in the vagina, and this is the tandem that goes inside the cervix, and this is the place of the tumor. With the modern imaging techniques, we can actually see the tumor quite well, and we can outline it, and we can adjust the dwell time, or how long that little radioactive seed is going to stay in the different parts of the applicator, depending on the dose that we would like to deliver. I think it's always important to look in our results, and I encourage all the young people to look in their results. And it may not be a very scientific way, and it may not be completely statistically sound way, but it's important that you look at what you do and what your results are. So these are our results for the last 4 years. Since we've introduced this system. We've treated 159 patients. Most of them were stage 2 and 3 at diagnosis. And indeed, we had some young ones. But actually, most of the cancers were in the women in their 50s, 60s, and 70 years. The mean follow-up is 21 months. But then the range is actually very wide, just because I've included all the patients that we've done. This is the disease-free survival. Disease-free survival, as you can see, it is in very high 60%, even 5 years. With 5 years follow-up. Admittedly, we don't have that many people that we followed up for 5 years. The other interesting thing is that most of the recurrences actually happen in the first 2 to 3 years. So doing some sort of very extended follow-ups is not bringing us much. All the recurrences do happen in the first 2 years effectively. So whoever hasn't had a recurrence in 2 years pretty much will be fine, at least from a cancer point of view. This is the overall survival. It's a little bit low. Not all the patients were very young, and 5 or 6 patients actually died of other reasons, being clear of the disease. Important to look at the recurrences. We have 35 of them. And probably this is this is the most important slide for me, although it's very simple. We had 35 recurrences in total. From them, most of the recurrences were actually distant. 25 out of 35, or actually 30 out of 35 had metastatic disease, and 5 of them had a local recurrence as well. From the people that had local recurrence, we had only 5. So the combination of external beam radiotherapy and brachytherapy is actually a very potent combination, and mostly we do control the disease locally. And when you look at, I think I have another slide, who are the patients that actually develop a recurrence? Usually these were the people that we didn't manage to give the full course of treatment for various reasons. One of the patients had a Klebsiella infection that was resistant to everything from the previous surgical procedures. Some of them had a medical conditions that did not allow us to put them under general anesthetic after the first fraction and so on. But from people that we've managed to give the full 3 fractions, which is our standard course of treatment, we almost don't have isolated local recurrences. There is an alternative schedule that is being used, 3 versus 4 fractions. There wasn't any real difference. Extremely rarely we use 4 fractions instead of 3. With 4 fractions we give a slightly lower dose, but extra fraction. There is no significant difference. This is what I've mentioned already. If the patient managed to get 3 fractions of radiotherapy, the chances of local recurrence is actually very low, pretty much non-existent. We're not going to go to different toxicity grades, because as any treatment, radiotherapy does have some toxicity, but these are the GI and the GU toxicities. So a little bit of upset of the bladder and a little bit of upset of the rectum is actually quite common. People go more often to the toilet. They have a bit of urgency on bowel motions and urgency on passing urine, and this is grade 1. Very rarely we need to do something for this, and we have to give them some medication, which is pretty much the grade grade 2 toxicity. Grade 3, however, also happens. It is not very common, but it is not unusual. And this is the typical example. This is not my patient. I took it from internet just because gastroenterologists haven't made me enough, haven't made me pictures. But this is the telangiectasias in the rectum. Normally they have some rectal bleeding. If it's a drop of blood on the toilet paper, it's probably all right. In rare cases, however, it could be more severe. And then the argon plasma coagulation is an excellent treatment. There was a time when we used formaldehyde in order to paint these telangiectatic changes in the rectum. And these days, argon plasma coagulation actually does a wonderful job. And the gastroenterologists are quite good with this. They use it for varices and for other things. So doing the rectum for them is not a problem at all. In brief, radiotherapy is a powerful tool in the management of cervical cancer. Please don't forget about that. Surgery should be retained only for the early stage of the disease. In almost all cases, having to use radiotherapy after surgery should be regarded as a missed opportunity to stage and assess the patient properly. And we have to resurrect that vaccination program. And yes, we have to vaccinate the boys too. Thank you for listening to me.